Gordon Lightfoot, 1974, and the quote there was, "Sometimes I think it's a shame when I think I'm feeling better when I'm feeling no pain." So this has been known for quite some time in terms of the dark side of drug addiction. So we've heard a lot about pain pathways and the addiction and resistance to cessation. And now I'm going to talk about using an analgesic and antidepressant medication to combat nicotine self-administration in rats. I really couldn't do anything alone, not anymore. So there's just a raft of collaborators, technicians who are just very, very skilled and talented students, postdocs, and collaborators on the faculty and senior investigator level, and they're listed here. And then the fundings and COIs. This research was all supported by the P50 Drug Development Center from NIDA. But our lab also receives funding from other NIH institutes, from NIDA, which that does, NIHS and NIA, US EPA, Philip Morris International, John Templeton Foundation, Foundation for Smoke-Free World, and Autism Research Foundation. So we got a diverse portfolio there. Okay, so I just want to emphasize tobacco addiction does involve more than nicotinic systems and or more than dopamine systems. And the brain is an organ of communication, and here's, even from its most elementary unit, a neuron, you can see that it's all patterned after integration. And so although much of science is involved in a reductionistic endeavor, we as brain scientists and clinicians in terms of behavioral disorders need to be involved in integration. And so the fact is that different people smoke for different reasons, and actually the same person may smoke for different reasons at different times. So we speak of smoking or tobacco addiction as a unitary phenomenon, but just as there is no such thing as cancer, there are numerous types of cancers. There's no thing as autism. There are numerous types of autisms. There's no such thing as a tobacco addict or even any type of drug addict. There are numerous types of drug addicts and tobacco addicts. And so that we have to recognize the dispersion among them and respond appropriately. And so people do smoke, some for the reward, some for secondary cue reinforcement, cognitive improvement, habit, appetite suppression, stress alleviation, pain abatement, nicotine withdrawal relief, and certainly others. And so we have to embrace this complexity, and that these different behavioral effects involve different neural systems. And so how do they come together to engage in behavioral function, and how do these break down in terms of dysfunction? And so circus, no, wait a minute. That's where you can find a lot of this disordered function, but really it's circuits. So that this isn't a new sort of thing. People have recognized this for quite some time. Tom Insel, 9 years ago, had this landmark article about faulty circuits. And we have to recognize when we talk about circuits, it's just a metaphor. I mean, people have these lines and boxes connecting to each other as if the brain was consisted of numerous electrical circuits, and that's just a way of speaking about it. It's really much more complex than that. Back before people had electrical circuits, they looked at the brain organization as a pulmonary air pump, and that the ventricles would pump air through the system and move your limbs. And then we went through the telephone switchboard hypothesis and the computer hypothesis and the internet hypothesis and so forth. So it does not get stuck in our boxes that we connect with the arrows. So in any case, that being said, I will show circuits because we need to have a language to speak it about. But just keep in mind, these are metaphors. So Then you do have projections of the cholinergic system, of which nicotinic receptors are one subtype, along with muscarinic receptors, and it's been alluded to, and there are numerous different subtypes of nicotinic receptors to consider. But then you also have dopaminergic innervation, and people, including the director of NIDA, have posited this final common pathway of the ventral tegmental area to the nucleus accumbens as the sine qua non of drug addiction. But in fact, that's a critical part of it, but only a part of it, and that there are numerous other limbs of these circuits that play important roles in driving addiction. And so people have talked about the migration of locus of control from ventral striatum to the dorsal striatum, or the importance of frontal cortical function in terms of providing some inhibition of these urges. But we should expand that as well. So there are serotonergic limbs of the system, and these are involved, say, in appetitive mechanisms. And people talk a lot about the HPA axis, forgetting that the H stands for hypothalamus, which is involved not only in stress function, but also in appetitive function. So the co-option of not just the reward centers, but the appetitive centers in terms of the service of addiction may be important, and noradrenergic systems as well. So we've done a lot of work looking at combined treatments affecting different parts of the brain systems and see if they can improve this efficacy. So this has been with our NIDA P50 Center, and that in the rat model, we've looked at drug treatments that affected acetylcholine systems, primarily nicotinic systems, dopamine. We've looked at D1 and D2 systems, serotonin, norepinephrine, noradrenergic systems, and histamine systems. And this histamine is the kind of forgotten amine. I mean, usually when people talk about monoamine neurotransmitters, they talk about dopamine, serotonin, norepinephrine, but histamine is another monoamine. It's not just in your nasal passages, but also an important transmitter in the brain. And glutamate, and we've done a little bit of GABA work as well. But we are working in a rat model, self-administering nicotine IV. This is not the same as tobacco addiction. This does provide valuable information in terms of neural circuits involved, and has shown the same effects that clinically proven drugs that do improve cessation affect self-administration of nicotine. I'll show you those data, and it's been predictive in showing another sort of treatment that has been proven to be effective in people. So if you give chronic nicotine infusions, akin to giving a nicotine skin patch, but with a chronic infusion of a nicotine through a osmotic mini pump, you do see significant reductions in nicotine self-administration with chronic nicotine, and the same thing with varenicline and bupropion, both being effective in this model. So these are good validators in terms of the model reflecting what's being seen in human smokers. And then, I don't think I have it here, but lacaserin, which is a 5-HT2C agonist, the serotonin subtype agonist, which is clinically approved to suppress appetite in people who are morbidly obese, has been shown to significantly improve smoking cessation. Prior to that, we saw it to significantly reduce nicotine self-administration in rats, and so have others. But today I'm going to concentrate on amitifadine. So amitifadine is a triple reuptake inhibitor, by which I mean the three principal or most commonly associated monoamine transmitters: dopamine, norepinephrine, and serotonin, with emphasis on serotonin. To inhibit their reuptake, it's been developed as an antidepressant drug, but also there's some indication that it may be effective in suppressing nicotine self-administration. So here's a molecular model of amitifadine, and here's a a article that we published a few years ago showing that it does reduce nicotine self-administration in rats acutely. Certainly we can have a dose effect function of acute doses of amitifadine reducing nicotine self-administration in terms of infusions per session, 1 hour session. And here is over the course of a session, these are 45-minute sessions, and that it has effects throughout the session. And then we looked at it on food to want to see how specific or general the effects were. The high dose, the 30 milligram per kilogram dose, did cause a decrease in food self-administration, but the threshold for that effect was at 10, between 10 and 30. And then you can see that here with panel A across the course of the session and breaking down into subparts of the session in the second part of the panel B. So we chose 10 milligram per kilogram to follow up with the chronic studies. Here you can see 30 also causes a degree of locomotor hypoactivity, but no significant effect with 10. So that's why we chose 10 to follow up. And then here we gave, in a between animals study, some animals received only placebo injections on a daily basis, and then others received 10 milligrams per kilogram per day of amitifadine. Here you can see our model is one where we pre-train the rats to self-administer nicotine and then sort them into matched groups and have as many high and low responders in each of the treatment groups, and then continue to test them over a couple of weeks of self-administration. Then we have a period of enforced abstinence. And so this is modeling a cessation attempt, and we can't really ask the rats to quit using nicotine. They wouldn't understand what we're saying. But we do keep them out of the operant situation. It's not an extinguish or a manipulation to extinguish their responding, but the fact is they don't even have the opportunity to. So this is similar to what people go through in terms of the last cigarette they had was a good cigarette. And so that they then self-impose or have imposed upon them some restriction on whether they will then have cigarettes to smoke. But eventually, they are out into the real world, and they're walking past the 7-Eleven, and they have the choice to walk in and buy a pack of cigarettes or to ask a friend to bum a cigarette or something. And so the fact is, how much do they relapse? So we have this resumption period after the period of enforced abstinence to see if the treatment is still having its effect. And here the chronic amitifadine had effects in both ongoing self-administration as well as this resumed access. And then here's the session-by-session data. It's pretty consistent and pretty clear. So then we asked, what about a combined treatment? So here, the standard that we used was a nicotine skin patch or chronic nicotine infusion treatment. So we have another article that's just coming out, has been accepted for publication, is on the website, and it will be available. Well, they don't actually have print copies anymore, so it'll be available in electronic form. And the SRNT journal, Nicotine and Tobacco Research, came out this year. And so this looked at the effects of amitifadine in combination with nicotine or not. And, I forgot to tell you, amitifadine, no drug is completely specific, and amitifadine certainly is not, having these multiple reuptake inhibitor effects. But it also inhibits the CYP2B6 enzyme, which catabolizes nicotine. So it may have an effect on nicotine in that regard as well. And so here's the scheme of the study, where we had pre-training and catheter placement and self-administration training and testing with nicotine treatment, chronic administration of nicotine via an osmotic mini pump implanted subcutaneously, modeling the same zero-order kinetic as a nicotine skin patch, a period of enforced abstinence, and also this chronic amitifadine that came in a week later. And so that spanned the period of self-administration testing, and then over into this resumption period. And then we added on another piece because, yeah, I mean, you could give drugs forever, drug treatments, and maybe you should give them for very extended periods of time. But we were wondering, is there a persistent reduction in nicotine self-administration even after you stop the drug treatment? So we added that particular part as a test. And so here are the results of the study, where you can see on the control panel that animals self-administered a fair amount and then continued to increase during the period of self-administration and maintain that increase during the resumption period and the post-treatment period, although post-treatment meant nothing to them because they only received placebo treatments all along. And the Amitifadine, again, it's 10 milligrams per kilogram per day, caused a significant reduction in the nicotine self-administration relative to controls that persisted after the resumption, during the resumption period. But as you can see, after we stopped the Amitifadine, it jumps right back up to where the controls were. So that was a problem, because then if you stopped with the treatment, then they would relapse, presumably. Nicotine treatment alone, as had been seen prior in our studies and in people's studies with rats and also with people, does significantly reduce nicotine self-administration, and has been found in people to significantly reduce or enhance cessation rates. But again, whenever you stop the treatment, they increased a bit and were no longer significantly less than controls. And then the most important panel, I believe, is the combination of Amitifadine and nicotine, where you saw a greater effect in reducing the nicotine self-administration during the active period of self-administration, during the period of resumed access, and then even after both treatments were removed, you saw a jump in responding, but really it's still significantly below the control levels of performance. So that it's the combined exposure, I think, that is really quite a bit more effective. It may be related to this inhibition of the catabolism of nicotine, or it may just be a straight-out effect of having this experience of not self-administering for quite some time, and with the combined treatment. And then here are the more detailed data day to day. And so you can see that with the climbing back to prior levels of self-administration with the single treatments alone, an increase during the withdrawal period or post-treatment period with the combined exposure, but still significantly less than the placebo control. The other thing that I wanted to point out is that how much does this carry over from nicotine self-administration and tobacco addiction, presumably, as we're trying to model, to other sorts of drug abuse? So is it not just for nicotine? So we did a study on Amitifadine and Remifentanil, a short-acting opiate drug, and rats will self-administer quite a bit of this stuff. As you might remember from the y-axis of the previous studies, it was quite a bit lower self-administration for nicotine than for Remifentanil. And here Remifentanil, they're self-administering quite a bit. This is the Acute drug study, where we looked at phase 1 and phase 2. Refers to, we went through the dose effect function in a randomized counterbalance design one time, and then we did it again. So here you can see overall that there was a dose-related decrease in nicotine self-administration. And as we did earlier, we followed up with a chronic study with 10 milligrams per kilogram per day of Remifentanil. And at this point, what we do is we train up the rats on self-administration, and then we regularly divide them into high and low responders based on their pre-treatment baseline performance. Because rather than throwing away those rats who really don't care very much to self-administer the drug, and only concentrating on those that self-administer quite a bit, we do both, because there are some people who are like light intermittent smokers or chippers in the opiate world who do it occasionally, and but still it's a problem that they continue to do it. And certainly light and intermittent smokers are addicted to smoking, although probably in a different way, not in terms of trying to alleviate withdrawal effects, because they don't really show withdrawal effects, but in terms of inability to stop smoking despite the fact that they know that it's doing their health harm. But in any case, here we did find a difference in low and high responders. So the effect of amitifadine was quite a bit more effective. It was more efficacious in the low baseline performers. They did show some effect in the high baseline performers, but not as much as in the low. And then here's the overall day-by-day data collapsed across those subgroups, but showing you that amitifadine is not the cure-all. Certainly, it causes a significant decrease in nicotine or in remifentanil self-administration. But as you can see throughout the period of the study, that animals receiving the amitifadine, like those receiving the placebo control, did show increases in nicotine self-administration in a largely parallel pattern. So it's suppressing it, but not eliminating the acquisition of it. So certainly there are other things we need to do to follow up on that in terms of the optimizing the dose that we're giving. Maybe we need to give a higher dose, or maybe there's another analog of amitifadine that may be more efficacious, or a combination of amitifadine and another drug that may be more efficacious. But in essence, it does lower the reinforcing value of the remifentanil. And the fact that remifentanil is catabolized through quick-acting esterases, not through CYP enzymes. So the the inhibition of CYP enzymes by the amitifadine doesn't seem to be playing a role here, as it may with nicotine, but it's still having a significant effect. Now, the question is, if you wanted to have a treatment for people who are taking opiates for pain, it wouldn't do any good if it's also suppressed the analgesic effect of the opiate, because that's what the therapeutic goal is to suppress the pain. So Amir Razvani led the collaboration on this part of it, especially in terms of looking at the hot plate response. So here you can see that remifentanil caused a very, very significant analgesic effect on the hot plate, which was relatively short-lived, as you can see with the remifentanil alone graph, or bar on the graph, the gray bar, the dark gray bar, and that it then was done 20 minutes after the injection. So, but that the combination with amitifadine did not in any perceived way suppress this, which is good news, because this is the same dose range where we found it to be of 10 milligrams per kilogram to suppress nicotine or remifentanil self-administration. And then, interestingly enough, remifentanil alone caused a significant degree of analgesia in this test, in the hot plate test, that it was far less to begin with compared to remifentanil. But you can see, even starting at the 5-minute time point, it was significant and actually continued out. It's more long-lasting than the remifentanil analgesic effect. So here you have a treatment that could suppress the reinforcing value of the opiate, but not suppress and actually augment the antinociceptive effect of your opiate. So I think it shows good promise for further development. So in summary, as with humans, nicotine, varenicline, and bupropion administration significantly reduces nicotine self-administration, so kind of serving as a validation of the model. And in addition, as I mentioned, it actually served as a predictor in terms of lacaserin, the 5-HT2 agonist, significantly reducing nicotine self-administration in the rat model in our lab and in other labs as well, and also then being tested in humans and showing a facilitation of smoking cessation. But to the main point of this presentation, the triple monoamine reuptake inhibitor amitifadine being developed as an antidepressant significantly decreased nicotine self-administration acutely and chronically, and then importantly chronically at doses that did not suppress food-motivated responding or locomotor activity. So it wasn't just a secondary effect of general debilitation or sedation. Amitifadine prolongs the effectiveness of nicotine treatment, and acute and chronic amitifadine decreases self-administration not only of nicotine but of the opiate remifentanil, and then did not diminish the analgesic effect of remifentanil and produced a long-lasting analgesic effect on its own. So the next steps to determine the efficacy of amitifadine for promoting reduction, it should be and elimination of tobacco and opiate abuse in people. So that's something we hope to do in the future, and also determine neurobehavioral mechanisms by which it's causing this reduction in terms of locus of action and the specific pharmacological aspects of its diverse effects that are underlying the effectiveness, so that we could maybe potentiate the effect with a second drug interaction, or maybe have a follow-on drug that would have a different ratio of monoamine uptake inhibition that would even be more on target. And to test amitifadine effects in other types of drugs of abuse. As a bookend, I thought it would be nice for this 25th anniversary of our, not 25th anniversary, 24th anniversary of our first one, as Jed pointed out, to say, here we have a map of North America as conceived in 1650. We knew probably pretty well what's going on in the East Coast. Maybe Florida was a little fatter back then. Maybe the sea levels were lower, I don't know. But in any case, there were areas that we acknowledged we didn't know, and terra incognita and terra miscognita, which we always have to be aware of. There is no ion channel of the Strait of California, but the cul-de-sac of the Sea of Cortez. So with that, thank you for your attention.
Thanks, Ed, very much. And open up for questions. One, Scott back here.
Great talk, Ed. Very interesting. So amitifadine is also blocking dopamine reuptake. Has it been tested for self-reinforcing properties?
Yeah, I guess that may be adding to that. Now, in the audience, we have a distinguished visitor here, the president of the company that is developing amitifadine. So if we need any further details on its actions, Tony McKinney is here from Intismos.
Yeah, this is Anthony McKinney again. The compound has, it's a 96 nanomolar dopamine reuptake inhibitor. So it has relatively low activity against dopamine. And Ed mentioned about the locomotor activation. It doesn't cause locomotor activation in any laboratory. It's been studied in about 3 or 4 different laboratories, no matter the population of species. In fact, you notice in Ed's study, at very high doses, it depresses locomotor activation. That's probably norepinephrine effect. And there's no drug that's abusable because of dopamine that causes a reduction in locomotor activation. They all cause an increase in locomotor activation. We have not done an occupancy study at DAT, but our estimate is somewhere in the middle to high teens for DAT occupancy. And the studies by Dr. Volkov suggest that at 50 and above, drugs with that level of DAT occupancy would be abused. Most importantly, this is a reuptake inhibitor, and its rate of rise for DAT is actually quite slow, whereas drugs that are abused have DAT activity that are very precipitous and high. We've studied it in about over 10 trials, 415 patients from normal subjects have received the drug up to doses of 600 milligrams, and there have never been a report of people getting high. So And actually, what happens with triples is that the two preceding monoamine activities cause the primary pharmacology. So what happens is people get sick first before they would get high. So there's the potential for this drug to have a non-scheduled possibility. But I wouldn't bet on it. I think this drug is probably going to get a C5 or a C4 because it does have dopamine.
Okay, thanks. Any other questions? Iman. Oh, wait, can you wait for the mic?
That, Steve Negus at VCU did test the compound in ICSS, intracranial self-administration stimulation, and at 3.2, at 3 milligram or so, didn't find any effect, does not facilitate the reward system. When he pushed the dose at 10, I think like you did, there was a biphasic effect, and it ended up depressing, in fact, not enhancing at a lower frequency. So yeah, it doesn't seem to have any in the animal abuse liability, but it does reverse pain, acute pain-induced depression of ICSS, which shows its ability to, at least in acute pain, like you did in the hot plate, they did in acetic acid-induced depression. But I don't think if there's known on the chronic pain models.
I see. Okay.
Thanks.
That's a really important paper. Everyone can read Miller 2015.
Read Miller 2015.
Okay.
Miller 2015.
Okay, thanks.
All right, well, any other specific questions before we open up to general? Oh,
Alexei.
yes, Alexei.
Thank you. Very good presentation. Thank you, Ed. Just a brief question. Do you have a data about nicotine after Amitifadine in rats? How much it will affect?
Oh, you mean the kinetic effect?
Oh, not literally kinetic, but at least after each injection, yeah, what was level nicotine compared?
Yeah, we haven't done the kinetics of it in terms of the uptake or the how long-lasting the nicotine was with the Amitifadine on board. Certainly, it decreased the self-administration, but that would be a follow-up study in terms of, and that would help answer the question of, is it this suppression of the CYP enzyme that was driving the greater efficacy with chronic nicotine?
That's correct.
Yeah.
Because in general, if it's really boost the nicotine in blood much higher after that, you should just reduce the dose for this animal,
Right.
disentangle what is truly nicotine effect or.
Well, and then the fact that it's effective against remifentanil, which it presumably doesn't affect
Yes, that's correct.
the metabolism because it's metabolized in a very, very different way.
That's true.
Suggests that it's more of an anti-reinforcement. Yeah.
Thank you.
Yep. Eden.
Essentially the same question. Good question and great talk. I just obviously you use the same dose in the nicotine group and the nicotine plus amitifadine.
Yes.
Yeah. So.
Yeah. Okay. Well, thank you.
Great. Oh, I think it's off, sorry.
We can have a more general discussion, and anything's fair game. You know, what we presented in the different presentations today and things that we haven't touched on that would you consider to be important.
I
Alexei.
believe Dr. Mukin has a question.
I have a topic for discussion because in many presentations today we heard about time profile, how it change over time effect of nicotine. And because it's different receptor subtypes, something during smoking, for example, we can observe some effect without nicotine. Could we expect that temporal profile for different effects in different observation could be different? That will help us to understand the nature of these effects. Thank you.
So would you mean that, for example, if it was an alpha-7 effect, it might desensitize very rapidly, or even alpha-4, beta-2, it might just come on, then go away quickly, but if something's more prolonged, it might imply some other
For example, craving, when it's appear, when it's disappear.
yeah.
After the next cigarette, when it disappear, you have side effect. With next, when it disappear.
Time.
Analgesic, when it's appear, how fast,
Right.
when it disappear.
So the time course.
The time frame
Sure.
for different effects
Sure.
of nicotine. It can give us some, I believe, picture about some common or
Yeah.
individual mechanism of nicotine, including different receptors.
Right.
Yeah,
Well,
good point, yeah.
And so like the things I've talked about, that the diverse effects of nicotinic systems in these different circuits, that there are repetitive effects and reinforcement effects and attentional effects and mood effects, that even in a same person, that you may have different effects at different times that are driving the behavior. And given the desensitization profile of nicotinic receptors, certainly the first cigarette in the morning is quite different than other cigarettes during the day. And your treatment's being tailored to what's driving relapse. And if it's relapse after a period of abstinence, then it seems like the agonist effect would predominate in terms of whether that initial lapse would turn into a relapse, right? Yeah.
Kind of just as a follow-up to what you just said, Ed, your first slide, it is so important, this is a clinical statement, for all of us in the treating community to realize that it's terribly important to ask our patients how that cigarette helps. Because once we've opened that door, number one, we begin to move away from the shame and judgment and learn a tremendous amount about what it does, because I thought your lead-in was so important. Because for each different patient, there may be such radically different reasons that they smoke. And I guess the other observation that I would make, and it's one more of a statement or a whine perhaps, and that is, as I said in a wonderful conference, and that's not false praise, what is terribly frustrating is to know that many of the major treatment centers in this country who, quote unquote, treat both addictive illness and pain do not have any emphasis whatsoever on cessation of nicotine. And I want to hurt them. I mean,
Cause them pain.
Right, I want to cause them pain. I want to elevate their anhedonia. I mean, it is, but it really, and I don't know how to get this information to them, but it's just really a profound, as I sat here today going, I just want to scream.
Well,
Thanks.
Unfortunately, if there's 500,000 premature deaths a year from smoking tobacco, and that's been going on for how long? I mean, it's remarkable to me, as terrible as these vaping deaths have been in this past year, it's just minuscule compared to what we've had going on for decades and still have it going on. So the cost of doing nothing is considerable, and it's kind of accepted because it's kind of put off into the future on any particular life of, oh, I'll smoke now and I might get cancer 30 years from now, versus, I'm having trouble today.
To respond to your comment, I agree with you, and I think that the Barua paper, which is an American College of Cardiology treatment guidelines, is a start. And if it can come out, also written, by the Society for Pain Medicine, or something along those lines, where it becomes, that's how it becomes standard of care. And that's how I think you let clinicians know that it's actually an expectation. Yeah.
Yeah, here.
With both pain and sort of psychiatric conditions and mental illness, one thing I hadn't heard is whether or not there are differential gender effects in any of this work. It would seem to me that if you're looking at affect, it's expressed differently in its relationship to, given our research, given to relationship to various forms of distress may be different. work I've done with regard to eating disorders and this kind of thing indicates that affect has a different, almost reverse effect on men and women. So I'm just curious.
There was, at least one presentation had some gender data, but
I might have not been here for that.
I think there are strong gender effects in affective disorders. We don't see it in psychotic disorders. It may be that the impact of psychotic disorder swamps the impact of gender.
well, and just in terms of pain, an anecdote, I remember there was a movie, a Charlton Heston movie called The Warlord. I don't know if anyone remembers that. And there was a point where they were cauterizing his wound, and very, very painful. And somebody said, you know, get 4 strong men to hold him down during that painful procedure. And somebody else said, no, just one woman will do it, because men wouldn't want to show pain in front of the woman. So.
And actually, we've done some sex difference work with the rats, and we actually looked at nicotine self-administration over the estrous cycle, and unlike with cocaine, which does show a significant difference over the estrous cycle, we did not see nicotine to have that same effect, and Eric Donnie had the same finding. And then in terms of these drug effects, for a number of the compounds that we found to be effective in female rats, we found the same sort of effects in male rats, even though male rats generally self-administer more nicotine than female rats on a per kilogram basis, but the drug effects seem to be similar.
If I can come back to the vaping issue. Can't stay away from vaping, because I think it relates to what Eden was mentioning about the transitory nature of treatment and problems with adherence that Joe McKernan was mentioning, is that the New England Journal of Medicine paper by Hayek et al. A few months ago that showed that abstinence rates using e-cigarettes were twice as high as state-of-the-art combination nicotine replacement therapy, also found that 70% of the successes were still using the e-cigarettes 1 year later. Now, some people decry that as, oh, how terrible, they're just substituting one addiction for the other. But the other side of that coin is there is a treatment where adherence is extremely good in the long term. So if it turns out that you need indefinite treatment in some populations, how likely is it that people will, you know, comply or adhere to popping pills or patches year after year after year, as opposed to using something that's addictive year after year after year? Politically incorrect, but in terms of a pragmatic goal of keeping people on a treatment that keeps them from going to the most lethal form of nicotine, i.e. the burning cigarette, then I think it should be seriously considered, and we just need to learn more about what the long-term health effects are.
The other thing I was going to point out before Eden starts is a kind of a confession of animal researchers, is that the animal model of nicotine self-administration is really not very good, because it's not very reinforcing in animals. Certainly, you can show that it's reinforcing, but in a fairly narrow dose range, and as you saw the difference between the nicotine and the remifentanil, the rats self-administered at a pretty low level. And so you don't see the kind of compulsive, addictive sort of behavior developing in the rats to just plain nicotine, as you see with people smoking cigarettes. So it's still a matter that's not at all known. What is it about cigarette smoking that is so damn addictive? And it may be, you know, the relationship of the behavior to the administration of the drug, or maybe it's the administration of drugs, not just nicotine, but other components in tobacco as well, that may be underlying the great addictiveness of tobacco smoking. And in which case would say that maybe in the simpler chemistry of the vaping device of just nicotine and few other components, is it less addictive and easier to come off of? That's something that's completely unknown, and we need to find out.
So I want to come back to what you just said about vaping, but just to comment on not knowing how long to treat, chronic treatment, some of David Gilbert's work, that the withdrawal symptoms last for a long, long time. We have a number of patients who've been on and off of varenicline for 5 years now. They can't get often insurance coverage after a while. They pay for it themselves, but they'll be off of the varenicline, off of the cigarettes, do fine, have a stressor, start having urges, and rather than smoke, call us up and get and take it for 6 weeks or so. And most of them get a little bit of nausea, so they want to go off of it eventually because of that nausea is unpleasant. But essentially, it's become an intermittent tool to stay off of tobacco, which just speaks to this lasting craving. It's a learned response to stress is one way that I think of it.
Yeah.
Oh,
And
and
what do
the
you wanna say about-
addictiveness of vaping.
Yes,
So we have just started in response to schools starting clinics in our area and a clinic for kids who are vaping, who've never smoked.
Yeah.
So it's remarkable. We've been doing longitudinal. We've been paying kids to quit smoking pot, David. And to measure the effect of abstinence on their ability to learn. But in this, we've done surveys of vaping and ever smokers, never smokers, and ever and daily vapors. So the vaping is incredibly persistent. So of those who've ever vaped weekly, 75% are vaping daily currently.
I see.
Which is the same as what we see with smoked tobacco. And there's a cry, there's requests for us to do treatment, but I don't know what to do. So I'd love to talk to anybody who's got data.
So do the treatments to help people quit smoking cigarettes, varenicline, ibupropion, and nicotine patch, do those help people who are, haven't started, yeah.
And part of the, well, I don't know, part of the problem, and it could be the frequency of use, and this is a whole topic within vaping of, every 30-day use, weekly use, daily use, and a lot of the so-called epidemic of addiction is based on monthly use. And if you look at 20 or more days a month use, and in novices who are not already smoking tobacco, the National Youth Tobacco Survey shows it's only a couple few percent of high schoolers.
That's been changing.
Yeah, since 2018.
Yeah.
Right, but I think that's changing.
Yeah.
So it needs to
I
be
mean,
continually
the other
monitored.
thing is the societal constraints. So I think some of the, not only are fewer people smoking cigarettes, but they're smoking fewer cigarettes. And a lot of that is the great public health advances have been the societal constraints of where you can smoke, and the fact that smoking puts out a stink is that there's tremendous restrictions on where you can smoke, whereas vaping is, you can do it surreptitiously much more easily. And yeah, exactly. Yeah.
Let me ask a question from the standpoint of anhedonia and reward enhancement. Now, is it true that the FDA considers euphoria, if a drug produces euphoria, that's abuse liability, and that's considered a negative thing about that drug in terms of scheduling and so forth? How would reward enhancement put a drug in a kind of adverse scheduling position? Does anyone know? I wonder.
I don't know. I mean, you could make the claim that antidepressant drugs are, enhancing reinforcement, right?
Well, exactly. Antidepressant drugs
Yeah.
would be in that category.
But
so.
they're not scheduled, other than ketamine. I mean, that's scheduled because it has abuse liability, but tricyclics aren't, or SSRIs aren't. Yeah. Great. Other points?
Points?
Well,
Now we really have covered every
everything.
point, except perhaps to thank you all for coming.
Yeah.
Thank the wonderful, uniformly excellent speakers of the day. Thank my colleague and co-organizer, Ed Levin. I think of the 25 conferences, some informal feedback. I think today may have been in the top few. So we're certainly not getting worse over time,
but
so
I
maybe
can,
we're getting better.
I can reassure you, we have not answered all the questions.
That's right.
So
So there might be a 26th.
There you go. And I really thank everyone. Thank Jed for putting these things together. Thank all the folks in your lab or your clinic who have done all the logistics.
Yeah, I thank David Campbell sitting back there for his outstanding logistical support.
And look forward to seeing you guys next year.